privacy. All right. So I've explained it to her. I've asked her if she's ever had an assessment before, and I'm going to tell you something. Because of the way that you're going to be doing this assessment, which is textbook, do not be surprised if your patient said, "Why are you doing that? No one's ever done that before." Don't be surprised, okay? I've explained what I'm going to do. I let them know I'm going to do their head-to-toe assessment, why, all of that good stuff. So I don't need you guys to say, "She didn't explain." I'm just going to go through and do the skill. Are you with me? All right, so with that said, first things first. Your stethoscope, the earpieces need to be pointing towards your eyeballs. There's no possible way you are correctly auscultating with the stethoscope pointed to the back of your head. It is an impossibility, okay? So I don't want to see that anymore either. That's first thing. Okay? Second, get yourself a good stethoscope. We're selling our stethoscopes on campus now. They're Littman-like quality if you need one. All right. So the first thing that I'm going to do, and I have my pen light attached, I need a darkened room, don't I? Yes. Okay. So I do need your pen light, Andronika, only because I want to show everyone else. That's okay, I know the gauges. You have yours with gauges, okay. Everybody needs a pen light with gauges. Until you know and memorize the sizes, it's going to take you probably all through nursing school. But if you practice it, you'll get it down, all right? This is important. There's no way you're going to leave nursing school without knowing a pupil. I don't care if you choose not to go into neuro, you need to know this. Are you with me? All right, so get this, and then once you have it down pat, then you can switch to a different pen light. I like this one. I get it, again, in 12 years, I've only had, this is my second one. I get it from Walmart in the fishing section. Look how light this pen is, this pen light is. Can y'all see? Barely, right? But it works, and it doesn't blind the patient's eye. It's reactive, okay? The other thing, y'all are checking Perla in a room that's lit. How? How are you doing that exactly? You have to be in a dark room because you're checking to see if the pupils react to light. They're reacting to the light right now. Congrats. So you have to turn it off to see if it reacts to the light. So with that said, how do I turn this thing off? Let's hear.
On the remote.
Okay.
Light switch.
Just don't pull the thing out of the wall for us to have a code blue in room 38.
Right. They're gonna right there.
That's a light right there on the remote.
Yeah.
Don't leave me in the dark too long. So before I start, I don't want you to push it yet. Don't push it yet. Be ready to push it.
Try it, make sure.
Before I do each section, and the baby eyes are integumentary, okay? That's what that's for. So your last eye is just one sweep. The knee is what? The N is what? Neuro. Neuro and a baby eye, so integumentary. What's the re? Respiratory and integumentary. What's the C? Cardiac. What's the next one? GI. Next one. GU. Next one. And integumentary. And again, because I've been assessing the baby eye all the way through, my last integumentary is just a general sweep. It's not going to take that long. Additionally, knee, re, siggy, iggy, me, head to toe, it's also in order of importance. I don't want to see you starting with integumentary or even reporting to your instructor or your team leader your patient's report starting with integumentary. I don't care about the skin until I know about neuro, respiratory, and cardiac. Are you with me? Those are the three areas that your patient's going to die from the fastest. GI, will they die? Yeah, but it'll take some time. GU, it'll take some time. Musculoskeletal is not going to happen. Integumentary, well, with some time. Are you with me? So I'm doing it in order of priority. So the first thing, before I start each section, I ask a question. There is literally a question you can ask in each section. Is there not?
Yes.
For neuro, what question or set of questions can I ask?
Where are you?
Okay, so I'm going to do that. No closed-ended. Do you know where you are? Don't ask do you or can you.
Where are you?
All right, so please state your first and last name for me.
Jessica Moss.
And tell me where you are right now.
Florida, in Davenport.
And what's today's date?
6/20.
So, say what?
June 20th.
Okay. And tell me what brings you here. What's the last situation or last thing that you remember before coming in?
I had a bad headache.
Okay. All right. So is she alert and I would have to check that inside of the chart. That's what she came in. She had a pain 10 out of 10 and she ended up, with some sort of head thing and then she fell. So it's congruent with what I find in the chart. So she'd be A&O times 4. It used to be A&O times 3. Don't fall for that now. We've updated it to situation. So make sure you're charting A&O times 4. Are you guys also looking at the sheet that I've given you? Mm-hmm. Okay, the assessment sheet. You look at it, I want you to follow along and see. Okay? So that's the first thing that you do. I ask the question. Then, what's the next thing that I'm going to actually do? I'm going to now do my perla, okay? Now, perla, guys, you can't just do, even if we teach you how to do all of this stuff, if you don't know the why behind the why of what you're doing, and not to hurt anybody's feelings or I'm not being condescending, I can teach a monkey to do all of this. Literally, they're pretty smart. But I can't teach them to critically think why they're doing and what they're looking for. So if you don't know why you're doing all of these things or what it is that you're looking for, what's normal, what's abnormal, what it means for your patient, what separates you from a monkey? Nada. So you need to also, but start with the skill. Get the skill down and then also know what you're looking for and why, okay? So I'm going to assess perla. Pupils, I'm going to check to make sure that they're equal and that they are round. They can be different shapes than round, believe it or not. And that they react to my light and that they accommodate. So for accommodation, I'm going to jump to accommodation real quick. You guys do this oftentimes, but you don't have to do it that way. I'm going to show you another way to check for accommodation. Okay? All right, so I'm going to have you stare straight ahead for me, okay? And I'm going to shine a little light in your eye. Thank you. Look at that. So on point. Okay? And what I'm going to do, go ahead and keep your eyes open. And the reason why I have her stare straight ahead is because it'll keep her eyes open enough. We want to try to avoid having to do this to our patient. Are y'all with me? All right, but you may have to. So for me, I don't have to. She's going to look straight ahead. And this is what you do. This is the thing that you got to do. Okay? This right here, keep doing this and bringing it in and leaving it in there. It's going to leave your patient feeling blind. And they're going to I still see the red spots now from what I just did. So I really do, and it's uncomfortable. What you need to do is hold the pen light to the side, and you need to bring it in very slowly until you can actually see the pupil size, but not so much that it causes a restriction. Are you with me? Okay. Or a reaction to the light. So what I'm going to do, can y'all see? I'll go ahead and show everybody. Have I shown you before? You see it? No? Okay. So watch this. Can you see my pupil sizes? You see them?
I see.
Okay. So what size are they, would you say?
It's a
4 to 5. Okay. See how I did that? Now I'm going to, once I have it here, and this doesn't bother me. See how long I've held this here? Boom. See that? And that didn't hurt, as opposed to, you can't do that. I don't know why I keep doing that. Same thing. You bring it out to here until you can see the side. Can you see it? Angle it in. Boom. Got it? That's what you do. So you bring it out here until there's enough of a reflection that you can see the size, angle it in till it reacts, and that's it. Are you with me? Beautiful. So I did that with her on both sides. The other thing that you have to look for, though, you're checking to make sure that they're co-sensual. Co-sensual means that they do the same thing at the same time. So when I shine the light into the right eye, I know some people think only the right's going to constrict, and then you do it in the left, only the left's going to constrict, but they're on the same wire. So they should be, in theory, doing the same thing at the same time. If they're not, that's a problem as well. That tells me there's something going on with my optic nerve, or maybe a brain bleed, who knows? Or it could be a cataract as well, by the way. I love it when students tell me pearl is intact and I have a patient who has a cataract. I'll eat you up all day long if you tell me that. Okay? Perla can't be intact with cataracts. Anyway, so you kept your eyes straight, and I went ahead and I assessed this one, boom. And she's got larger pupils. Hers would be about a 7. Boom. And I found that they were equal, reactive to light. Now here's the thing as well. And they did the same thing. They were consensual. I have to look at how fast the pupils react to that light. Because sometimes they'll go, phoop. Other times they'll go, boom. Other times they won't. So you've got brisk, you have sluggish, and you have what? Non-reactive, okay? I know you've heard the term fixed. Fixed pupils are typically for people who are dead, okay? So try to avoid the term fixed. It's better to say non-reactive. Are you with me? Now, if your patient is dead, then it would be fixed, okay? All right, so that's the other thing. So I'm gonna have you stare straight ahead, and you can turn the light back on. Thank you for that. I'm gonna have you look at the tip of my pen light, and then I'm gonna have you look at the ceiling. So You didn't see that because the light is on, but I could see it because I'm in her face. What happened just now was the same thing, regardless of whether the light's on or not. When you look at something that's close and then you look at something that's far, your pupils are going to constrict and dilate. Are you with me? It's going to do the same exact thing then from having it be out here and bringing it all the way in here. I don't like to do this. I was taught to do this as well. But what happens is it causes your patient's eyes to cross, or sometimes they'll, and it hurts. It's actually very uncomfortable, especially for the amount of time that you're keeping it here. But when you have them stare at it and then look away, it doesn't do that to them. It's more comfortable than the other. So you can do it either way. Both will assess for the same thing. I prefer the first method that I showed you. All right, and I see that there was constriction and dilation. All right, that's my accommodation there. All right. The next thing that I'm going to check, I call them whiskers. Your neuro assessment is the longest part of your whole assessment, by the way. So I call them whiskers. The reason why is because boom, 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 huh? Boom. What happened? Oh, okay. Don't go into this one. Go into a different one. That's too weird, too close. Go somewhere else. Just go somewhere else. Just go somewhere else. Yeah, you can't do that. All right. Y'all are a trip. Y'all are a trip. So I call them whiskers, all right? I wouldn't say that to my patient, but I say it to the students because you think of, whiskers, right? And it's because you're checking for extraocular movement. Also, same thing, synonymous, cardinal gazes. They're the same. That's what you're looking for. Not this whole power of Christ compels you. I don't know what that is or where y'all learned that. That's not how it's to be done, okay? And the reason being is because you're checking for a couple of things. You're checking for your extraocular movements. How do things move? Because of the muscles, okay, and the eyes. So you're looking for both strabismus, nystagmus. Y'all need to know those words if you don't know them. All right, so what I'm gonna do is have you trace my pen, but don't move your head, okay? And then I'm going to move very slowly the first whisker. And I have to do it slowly because watch this. When I did that, she did have a little nystagmus that went on, and I know you don't normally have that condition. And then it's gonna hurt. And you're gonna have some patients that you're gonna go, they're gonna miss it. So your assessment's off. You have to give them time to track. And let it stay here for a second, and then go back and track. Are you guys with me? So you do all on one side first because you're checking, and then the other because we're checking for symmetry, yes? Okay, so what if you see your eyes doing like that? Is that normal? Okay. All right, so I've done all that. Do I need my pen light for anything else? This is this? No. I do not. So my pen light's done. Is that cool? The next thing that I'm going to do, notice that I'm doing all things neuro. Everything that's neuro related, I'm going to keep it in a box. So what I'm going to do is I'm going to cross my hand. Why am I crossing my hands?
Because your left is there.
Yeah.
Correct. And that will allow me to make sure that I can best assess the strength on the opposite side. Are you with me? And chart correctly. If I do it this way, there's two reasons. For one, if I do it this way, I actually don't have a good gauge of which one's stronger, which one's not. There's something about our neurological system that when we cross things over, we're better able to assess it. But you keep your arm straight. I'm crossing mine over. And now you tell them, go ahead and give me a good squeeze. I can handle it. Boom. And I'm looking, this one was mildly weaker. I don't know if you meant to do that. No, okay, there you go, equal strength. See, you know how I noticed that? And I tapped you, and then I know that's my left hand. I chart. Left hand, I would say that was 2+ strength. Her right hand, I would give 3+. So is it not symmetrical? It's not symmetrical. Are you with me? All right, because I keep everything in a box, I'm gonna go down to her feet, and I'm gonna do the same. Guys, excuse me, ladies. I'm gonna go down to her feet and do the same. Now I know there's like, push on a gas pedal, pull back, lift, all these weird different interventions for this. But guys, listen, what I'm checking for is two things. I'm actually, when I'm checking for grips, I'm checking both neurological and musculoskeletal. Am I not? So here's the thing. You wanna cut down your assessment time. You get more bang for your buck with this one move. I'm gonna press down on your feet and I want you to lift up against, okay? What moved when I did that? Her whole body. Are you with me? All right, I want you to press down like you're touching a gas pedal. And I want you to move up like you're, whatever, just pull up against my hands. I don't even know what y'all tell because I don't assess that way. Okay, so when I did that, look again, pull up, yep, What moved?
Only my calves.
Only her calves, okay? Press down gas pedal.
Only my calves.
And I also, right, exactly. But when I did this and you lift it up, it was everything anterior and posterior and the core. Are you guys with me? That tells me more neurologically, so I don't have to do 50 million different things. And then again, if you need to cross over on this one to help you out, you can, but I don't. I've got it figured out. When I get to the feet, it's just, I don't know, it's easier. All right, so you check that. Is there anything else with a neuro? Yes, there's gait. I can assess that, but guys, I don't like to assess my gait on my patient until the very end. And the truth of the matter is, in clinical, yes, in real world it's important, but in the clinical setting, it's something that can be deferred. Oftentimes when you're doing your assessment, your patient's trying to eat breakfast, they may not want to get up and walk around the room at that time. So if they don't want to do it, let's defer that. Plus, if they have orders to be on bed rest, they're not supposed to be up or only up to the bedside commode, you shouldn't be ambulating them anyway. Additionally, I don't want to get my patient out of bed if I haven't assessed to see whether or not we have a possible DVT. Because if I get them up and I ambulate them and they have a DVT, that DVT travels to the inferior vena cava, to the right atrium, right ventricle, tricuspid valve, right ventricle, to the lungs. I now have, through the pulmonary artery, I now have a pulmonary embolism caused by you. That's not what they're here for, right? So we need to be very careful about that. So knee. Additionally, one thing I didn't tell you is while I was looking and checking in her eyes, I was also looking at the skin on her face, okay? The other thing that you can do, and you can do this when I end up turning the patient, you can look behind the ears and behind the neck because that's where skin CA likes to hide out, and it would be okay to check that every shift or at least once for your baseline assessment. If you feel so thoroughly moved to check the scalp for any abnormalities, don't say you're looking for bugs. I can't hear that anymore. None of us instructors, we can't hear it one more time. If you feel like you gotta do it every shift or every 4 hours, then you can if you want to. I strongly recommend that if nothing else, only do it once per shift. Because really, if they didn't have bugs 4 hours ago, they're not gonna have them now. And they're not called bugs, right? Lice takes a while to develop. So, and typically we're not going to have it in this setting. Usually with kids if you work in an adolescent residential treatment and I had it a lot at Amistad when I worked with adolescents. But the bottom line is it's good for you to know how to do it, but you need to know when to do it. Okay? All right, so is there anything else within knee that I need to cover? No. See how I did that? I keep it in a box, and I didn't even have my piece of paper, and I stopped and did a lot of teaching and was interrupted multiple times and still did it. Are you with me? Knee. Re. So I can, how do I start off the assessment? I'm going to ask a question. What question can I ask in the respiratory system? Any shortness of breath? The other thing I'm also doing, and no, I'm no shortness of breath, I'm checking the breathing. I'm looking for the use of accessory muscles, okay? That's what I'm, labored breathing. I'm looking to see, all right? I don't see any of that. So I'm gonna proceed and I'm gonna listen to my lung sounds. Now, again, if you have somebody that tells you, do all your vitals and your assessment at the same time, you will not do that. Or do your respiratory and your cardiac assessment at the same time, you will not do that. You will not, because you can't. When you get out there, if you choose to do it and become a real world nurse, then do whatever you want to do. But while you're in school, you're not, because you don't have a solid foundation enough to be able to do that. You need to listen to the separate sounds. So I'm going to the first place I'm going to listen. I need to sit you up higher because I'm just not able to access you at all. That's not moving. Okay. There's something you gotta do that. Oh, it's only going up.
It might be the chords in a way. But it's a sensory bed. Yeah.
So you didn't move your bed down? No, you're sitting it up.
Sit up?
Oh, now I can do it. Was it the cord? Oh, that's
Yeah.
awesome. That's awesome. It has a sensor. Okay. So the first place I'm going to listen is above the clavicle. Are you with me? And I'm going to listen in a, how am I going to listen? Comparing
Both sides.
left to right. That's what I'm doing. So this whole thing is not correct because you have to hear and see if they're the same, right? All right. I'm listening for right above the clavicle here, and I'm going to do it above here again because that's where the apex of the lungs is located, believe it or not. Apex means tip. I'm gonna listen here, I'm gonna come down. It should be in a snake-like movement. Now the next thing, she's my student, and this is a demonstration, but you cannot listen to heart or lung sounds through the clothing. Did your textbook tell you to do that? I guarantee you it didn't. So you're gonna need to listen, skin, stethoscope to skin, period. Especially with those stethoscopes some of y'all have, they sound like the disposable isolation stethoscopes where everybody has diminished lung sounds. I'm not trying to hurt your feelings, but you need to put it on the skin. You're not gonna hear through the clothing. So that's the first thing, and you're gonna bring it over, you're gonna listen. How many lobes do I have on the left side?
2.
I'm sorry, hopefully you're okay with me doing all this. You wouldn't have volunteered if not. 2, okay? And then how many lobes do I have on the right side?
3.
I didn't see everybody answer, but okay.
That's okay,
Yeah,
that's
that's
okay.
okay.
So as long as y'all don't tell me that we have 2 and 2 or 3 and 3,
We're 6 and 8.
that's not accurate. That's just not accurate. And why do we have a difference between the left and the right? Because the heart is on the left side. There needs to make room for it. Beautiful. So notice that when I got to the bottom, the base, okay, the lower lobe, I'm listening to the side as well. Are you with me? Because as you know, the lungs flare out this way. Okay. So I'm going to do the same thing on the opposite side. This is the only time that I'm going to deviate from my assessment and not deviate from my assessment, but deviate from my box per se. I'm going to have you go ahead and turn over for me. Now, she's got a patient gown on. Right now, I can see everything back here, right? I can see it all, okay? So, and if she has on a brief, I'm going to explain to her what I'm doing, but I'm going to expose her. I'm explaining everything, so I don't need to keep saying that. This is the only time I'm going to deviate. Let me tell you why. Now that I have her flipped, I'm looking behind the ear. I'm looking behind the back of the neck, because this is where it can hide out. And again, I'm looking at skin. Notice I'm checking the eye. I also, when I did the lung sounds, I checked the skin on the chest. That's my baby eye for respiratory. I'm going to listen, same way that I listened before, same way. I'm gonna have her breathe normally, and then I'm gonna have her take some deep breaths, but not so deep throughout the whole assessment that my patient hyperventilates. Are you with me? If I can hear the airflow, why do I need them? Take a deep breath. What is it that what do you expect to hear more? There you hear them. What are you looking for? I don't know. So that you do that and they're, by the time you're done front and back, your patient's passed out on you. Now you're calling RRT.
Going back to your skin assessment,
Mhm.
it doesn't matter what age they are. It is our responsibility as RNs to assess all that skin, isn't it?
Absolutely.
It doesn't matter the age of the patient.
No. Why would that matter? Oh, somebody thinks maybe as a teen or as a... No, no, you do the same thing for everybody. See, that's not even a good real world practice. That's not a good practice at all. So I don't know where you got it. You check everything.
Make sure you ask them
Yes.
if they don't want to, take off their undergarments.
Oh,
if
you're
they don't
talking
want
about down here, the bottom,
No,
or the
I'm
back
talking
of
about
the
like
respiratory?
turning them and
Okay.
checking their skin on their back.
Yeah.
Of course I ask the
Right.
patient.
Yeah.
if-
You just, but you have to let them know what you're looking for, because guys, the truth of the matter is, they could be laying on their back, especially if they're not happy about being here. Most people are not. Skin breakdown does not take very long to happen, and it doesn't matter how old you are. It takes 2 hours for skin to start breaking down. Period. That's why we got a turn Q2.
Our patient who's here with a fractured hip on this floor, it's Jill's patient, has been here 15 hours and has told Jill and I that she was not turned or
15
repositioned her
hours.
pillows, and she has stage 1 on her sacrum,
Yeah.
coccyx about this big.
Yeah. So I'm not surprised by that.
15 hours and it is open.
And to digress for 1 second with integumentary, guys, if you have to look at your patient as if they're your baby. If your baby gets a diaper rash, that's on you, bad parenting. Your patient gets skin breakdown, it's on you, bad nurse. So you don't let that happen on your watch. So I'm going to continue to listen to all my lung sounds. I'm on camera, so I'm going to keep going. I'm going to listen to all of my lung sounds, and I'm going to do the same thing and listen to the side as well. Okay, the bases of the lungs. And I'm going to do the same thing over here. Are you with me? Okay, I am, because I'm listening to anterior and posterior. Then I'm going to, this is where I deviate, I'm going to do a full, and I'm looking at the skin integumentary, I'm going to do a full back sweep here. Now I'm deviating into GI, aren't I? But I need to do my skin assessment. I'm also checking back here. I'm checking the heels, a frequently missed place, a nice place for you to get breakdown as well. I'm checking all of it out. Are you with me? And then once I get what I need, I'm gonna turn you back. All right. And okay, sit back up. And I don't need to stutter too much because I'm gonna listen to the abdomen next, all right? So that's knee, re. Let me see if there's anything else respiratory wise. I already listened. And see how I'm checking myself right now because I have memorized what goes in my box. I've listened to the front, I've listened to the back, I've asked my question, I've looked, and there's nothing to palpate. There's usually something to palpate in each system. Nothing to palpate with respiratory except for one thing. Cap refill can technically go under respiratory or it can go under cardiac. So whichever works best for you as to, just as long as you remember it, it technically can go under respiratory as well, okay? I've seen it in hospitals under the respiratory box. But for me, it's just easier to keep it in cardiac because I think circulation. So that's where I'm gonna leave it. All right, so knee, re, sit. What's the next thing? Cardiac. So what do I do to start off and launch that box? I'm gonna ask a question. What question can I ask for cardiac?
Do you have any chest?
Are you experiencing any chest pain? Now, some of you guys, or palpitations, some of you guys have patients who have peripheral vascular stuff, or we're looking for maybe arterial conditions that they have. Maybe someone has come in or has a history of intermittent claudication. You can ask them something about that if it's specific to your patient, but just my general assessment, I'm gonna ask about the chest pain, okay? All right, so I'm gonna ask that question. Next thing that I'm gonna do is what? Listen. So now where am I listening? Ape to man. Second intercostal space, mid-clavicular line. All right, so I'm not gonna be all over you, but you need to know those landmarks. That is on an NCLEX, in the NCLEX test bank. It's also in the ATI test bank. It's gonna be one of those click, and you have a very narrow margin of error. So if you don't know that it is second intercostal space, intercostal means in between the ribs. Second space, okay, mid-clavicular, this is your clavicle, that's why AMP is so important, mid-clavicular line. If you don't know that that's where this is, you're not gonna hear the aortic valve closure here. So I'm listening to the aortic, and I come over to the opposite side, same landmarks, just on the left side, pulmonic. Then I'm gonna come to Erb's point, okay? Erb's point, y'all listening there, but you don't even know what you're listening for. And why are you listening there? First of all, what am I even listening for? I'm listening for murmurs. I need to hear normal S1, S2. I shouldn't hear S3 or S4. Gallop, any of that. I should just hear love dub, not love dub dub or love dub dub. None of those, okay? So here is what Erb's point is for. If you guys have never questioned it, I'm gonna take you from monkey to nursing. Are you ready? Erb's point, it's right in the center between aortic pulmonic and mitral and tricuspid. So I, at Erb's point, can hear any abnormal valve sounds, okay, any abnormal heart sounds, I can hear them equally here at Erb's point. So if I hear something abnormal, I didn't hear it aortic pulmonic, but I hear it at Erb's, I'm gonna continue to progress now down to tricuspid, okay, ape to man, APE, tricuspid, then, and you need to know those landmarks as well, tricuspid and then mitral, which is also the apex of my heart, the tip of my heart, and my PMI, point of maximum impulse, and where I assess my apical pulse. Stethoscope to skin, 1 fill minute. Got it? That needs to be done at least once per shift. I'm hearing you only have to do it if your patient's on digoxin. Erroneous, because I cannot assess for a pulse deficit without my apical pulse. That's the most accurate pulse in my body. Some of you are like, what is pulse deficit? Don't worry, I've got your back, okay? So I'm going to listen to all of this. Now, when I listen to the tricuspid and mitral, and I do hear abnormal, I hear an extra heart sound, Erb's point helped me with that, and it made sense because I heard it here, but I heard nothing at aortic and pulmonic. But I heard it at Erb's. Are you with me? And the reason why I heard it at Erb's and not above was because there was something located below. Got it? Understood. Now, where do I hear S1? I've never told any of you guys this. Where should I hear S1 and where should I hear S2? Where's S1? I'll give you a hint. Top or bottom? Where's S1?
Top.
Oh, you would think it's reversed. S1, S2. S1, S2. Between the Between the atria and the ventricles, which one's a priority room? Between the atria and the ventricles, which one of those are the priority room? It's the ventricle. Okay. So S1, that's the priority. Are you remembering that? I gave you an association. S1, ventricles, S2, aorta. Not aorta, atria. Are you with me? Okay, good. You'll remember that. Some of you guys haven't seen it yet, but you'll remember it. S1, S2. All right, so I'm also, because I already checked the skin on respiratory, I'm already good on my respiratory skin, on my cardiac skin, aren't I? At least for this part, because I did it when I was doing respiratory. So I asked a question, I listened. Is there anything else I need to listen to for cardiac? No, and I don't have a heart in the back, so I don't need to listen in the back. What do I need to do next? Feel. Pulses. I don't want to hear, well, I just went ahead and I just checked this one to make sure they have I just checked the distal pulses. If they have distal pulses, they got pulses. You're not a nurse, you don't get to make that judgment. Textbook says I have how many pulse sites? I start with my temporal, then I move to my carotid. Do I do both at the same time? No. Not unless you want this to be a very short assessment, all right? And then I'm gonna do my brachial at the same time, showing you where to find it. Make a bicep. I'm almost starting to see this bicep muscle underneath this adipose tissue. Make a bicep. Where you see, or not a bicep, bicep curl. Where you see the line between your bicep and your tricep, stick your 2 fingers in there, but not too firmly because you will obliterate the pulse. Lightly enough, and you can extend it there, and that'll cause the artery to pop, and you got it. Understood? So I'm going to check both of those. I'm seeing people say that the brachial artery is up here. Find the radial, go up here. I don't know where you got that from, but I showed you where to find it, and I assure you this is where the brachial artery is located. Then I'm going to move down and I'm going to assess my radial again at the same time because I am assessing for symmetry. I'm checking to see if they're equal and symmetrical bilaterally. Additionally, as I've assessed this radial, I'm gonna compare my radial pulse to my apical pulse. Now, should they be the same number?
No.
One is gonna
It
be
could
stronger
be.
than the other.
Should they be the same number?
Yes.
They should, because every time my heart beats, I need to know that I'm getting that number of perfused beats. Yeah. Or else we've got a mismatch here. We have a pulse deficit. And that's what that is. A pulse deficit is a difference between my apical pulse and my radial pulse. It can never be, your radial can never be more than the apical pulse. If it's more, it's human error, okay? It can only be equal or less. Understood? Okie dokie. So that's knee, re-sick. Okay, cardiac, the other thing, pulses. So you have other pulses located, but we're not going to be checking for those. Then you have a femoral pulse as well. We're not going to check that. I need you to know how to assess it, but this is the one thing I'm going to ask you to defer in clinical, unless your instructor says that she wants you to check for it. Maybe your patient had something in this area and you need to check for the pulses. That may be a different situation, but I wouldn't want people digging in my groin, to be completely honest with you. So again, this is us trying to treat our patients the way we wish to be treated. So we're going to defer on this, but popliteal, that's another one that's tough. So you need to bend your knee. You need to find that medial cartilage that you have there. It's holding that little knee together. It's more like a ligament, I'm sorry. And it's very tough. Mine feels like a cartilage because I have an injury. And you want to feel that and just inside of, just past that or lateral to that cartilage, just place your 2 fingers again, have her straighten her knee out, and that will do the same thing that happened with the brachial, and you'll feel the pulse, okay? It's hard to feel through the clothes, but I know that works, and I did feel a little something. So I'm gonna do that again on both sides, okay? Next thing I'm gonna do, I love it how you guys say, I checked the pedal pulse and it was good. That tells me you don't even know what you're doing, because there's not a pedal pulse. There's 2 pedal pulses, okay? So the first thing is, I'm gonna take your socks off. I got you, like we did to Nika. Yellow toenail polish. I know you fixed, just in case you were the demo. So you go between the 2 toes. This is the best way that I've done it. What I'm giving you are tips to landmarks, okay? Because they're hard pulses to find. So you put your fingers like this just between your big toe, your second toe here, lateral like that, and then you spin it around just like that, right here. Okay, you'll feel a bone, and as you do that, don't press it too hard, because if you do, and I feel your pulse through your sock, okay? This one is the back of the foot, so it's dorsalis pedis. Understood? This one is just in front, tibialis anterior. So you have the medial aspect of the ankle. You're going to slide your fingers just into the groove underneath the ankle, and you'll feel this one again. You have to, I may press it first till I get into the groove, but then I'm gonna lighten up. When I feel my pulse, I'm good. Your patient, it's very possible your patient won't have pedal pulses, or they'll be very weak, like a 1+. In that case, what do? Oh, I didn't feel the pulse, so I'm gonna report it and document it. So if I don't have a pulse, that means my feet are not getting circulation. And in daytime report last week, they mentioned that there was a patient who had no pulse in their foot for hours. Hours.
And they lost their foot.
Did they end up losing their foot? They ended up losing their foot because nurses were doing real world assessments.
Yeah, mine is about to lose this too.
Yep. You understand? But y'all aren't going to be a part of that. Your patient came in for like chest pain or headache, and they leave without their foot. It's beyond a problem, and it makes me, I'm irate because that could be my loved one, you know what I mean? Anyway, so I have felt, look, listen, feel. I've done all of that. Is there cardiac, one more thing that I need to feel, and I would have done it when I was down there. My cap refill. After you're done with radial, slide right into that so you keep it together, but notice, it doesn't matter that I missed it, it's still within the box. Are you seeing what I'm doing here? So it doesn't matter, and I didn't miss it because I get it done. So I'm checking cap refill. I'm also checking for symmetry. Don't just do one and say, oh, well, it's good. It may be good here, but is it good over here? And if it's different, what should be, and don't say good. I'm so tired of hearing good. Now we're not good if you say good. What does it mean? It's less than 3 seconds. If it's over 3 seconds, that shows me a delay in perfusion. And if I'm not perfusing here, on both sides, I'm not perfusing to any of my other tissues like that. This is representative of what's going on throughout the whole body. Are y'all with me? All right, so that's it. Now let me stop for a second and do my own sweep, cardiac, see if there's anything else that I've missed. There's nothing else that I've missed, but you can check your sheet and let me know. Now you have some stuff that's bolded, that's not bolded. There are some additional assessments that could be for your patient if they're on tele, et cetera, but that's not a part of my regular shift assessment, okay? So you may see that on the sheet, but what I'm showing you for cardiac, that's it. Knee, re-sig, GI. Now the rest of the assessment is almost done. That was the hardest part, as it should be, because that's the priority. Are you with me? All right, so the first thing I'm gonna do is, to kick off the section is, what question can I ask in GI?
When was your
Last
last?
bowel movement. A week ago, you say? Okay. Was that normal?
No.
No. Okay. Now, it's not normal according to the textbook. I always want you to compare to the text first. I'm going to ask, is that normal for you? Yeah, it is. Now, does that mean that that's okay? It doesn't, but it means that this is this person's baseline, and perhaps we need to do something so that this is no longer normal for them, because it's still not okay. Are you with me? The next thing that I'm going to do is what? Oh, and before I move on, I'm going to ask about the character of their last stool. All right? Right? So I'm going to check for COCA, color, odor, consistency, amount. COCA. Are you with me? Okay. So I know you're thinking odor, yeah, it all stinks. No. Let's be real here. Okay. Color, is it brown? Is it green? Is it yellow? Is it red? Is it black? The color of your stool can tell you about stuff going on with your patient that you did not get in report and that's not in the chart. Are you with me? You guys are using your assessment to be little investigators. Oh, you have black stools? Okay, what was the consistency? It was almost like tar and sticky. Okay, all right. And they came in for upper GI pain? Okay, all right. You see how I'm starting to think already? All right, y'all are with me. So the amount, it was a small amount. It was a large amount. It was liquid. Are you guys with me? Color, odor, and then odor. It could be malodorous. And when we say malodorous, we're talking about like either GI bleed type or seated. You'll never unsmell that. Someone said they couldn't smell it. Who was that in this clinical group that said, I can't smell them? They shouldn't have seen it if I can't smell it. You need to get checked by an ENT priest. You needed something, because that's a smell you can't not smell. All right, so the next thing I'm going to do, I'm going to look. All right, I have to look, What am I looking for? The integumentary. I'm looking for perhaps, yeah, you can see if there, oh yeah, I gotta tell you about the pulsation, right? I'm gonna look for the skin. I'm gonna see if there's any old incision sites, right? I'm gonna look at that. I can't tell you how many times that's happened. I have found something and it wasn't in the chart. Nobody knew about it because I actually looked at my patient's skin, right? And asked them, what about this scar here? Oh, I had this procedure done at this time, and it actually contributed to their condition. Problem solved. We get to fix that stuff. That's what we're here to do, guys, all right? So I'm looking. The other thing I'm gonna look for, I'm gonna use my shirt, not yours. I'm going to look for any pulsations. So you may see some mild pulsations in your patient's gown, but if you see anything that looks like they've got an alien that's about to burst out, that is textbook AAA. Textbook. Y'all know what that is? You have two types of aneurysms, okay? You have the ascending aortic aneurysm. That one is, oh my God, horrific. They both are. And then you have the abdominal aneurysm, okay? So the ascending, if you have a ruptured aneurysm, period, in the aorta, that's where we've got issues, guys. But let me tell you, this one, if they have a ruptured ascending aortic aneurysm, these people will bleed from every orifice, and there's nothing you can do to stop it. Nothing. No coding, I mean, think about it. If you code them, you're just going to push everything. What can you do? Nothing. You literally have to just be there with your patient as they die. So who prevents that? We do. Our assessment. Do your assessment the right way. So I'm looking for that. I don't see it. Thank goodness. She's going to make it through my shift. Then I'm going to look. I listen. And then I'm going to feel. So if you feel before you listen, you've changed the whole baseline. I'm going to listen, and I'm going to listen in a specific order. Seminole didn't teach me. They had me doing tic-tac-toe. They didn't care. But when I went to go do it, it needs to be done in a certain order. And you're starting in the right, the patient's right lower, right upper, left lower. You're moving in the order that the stool moves. And why am I moving that way? Remember, let's go from monkey to nursing. Why am I doing that? Because if I hear, and hold on, I'm not gonna just listen like this. I hear nurses say, well, if I listen, I hear a sound, I move. Nah, bro. And I said, nah, bro. Right lower quadrant for 1 full minute. You're listening for 5 to 35 sounds. If you hear 5 to 35 in 1 minute, you're normal active. Some of you are thinking, I really won't have the time to do that. Guys, you can do other things during that time. You can perhaps, if you're listening, so you can't really chit-chat with your patient, but maybe you've got a medication because you brought in your meds. I'm not telling you to do this in nursing school, but in the real world, I'm trying to show you how you'll be able to learn to multitask. Maybe I have an IV push medication I have to give that needs to go over 3 to 5 minutes. I can push a little bit and I'm listening. Push a tiny little bit and I'm listening. Do you see how I'm multitasking? There's a way to do it and be safe and not cut corners that will hurt your patient. 1 full minute, I hear normal active. 1 full minute, you good? You need a chair? You good? Okay. 1 full minute, I hear 7 sounds. I'm still normal active, aren't I? But it's dropped. 1 full minute, I hear 4 sounds. I'm now what? 1 full minute, I hear nothing. Now, what was I supposed to do in this one that I heard 4? 5 full minutes. So when you have an instructor tell you, I can show you a 10-minute assessment, they've lied to you. Because your GI assessment alone, if you've done it correctly, will almost be 10 minutes. Almost. Are y'all with me? And if it's abnormal, 5, 10, 15, 20 plus. Are y'all with me? That's GI. So I look, I listen, feel. Now you can do deep palpation, you can do light palpation, but as students, I want you guys to only do light palpation. Let me tell you why. We have a lot of GI things that I'm seeing going on in our community now more than ever. A lot of appendicitis, liver stuff, gallbladder, and what I don't want to happen on y'all's watch is for y'all to be doing deep palpation and rupture something. I don't. It's not your watch. It's actually our watch, our license. So really, we don't want you to be traumatized if anything happens. But just know, light palpation is fine. If your patient jumps or is guarding, that's the other thing you're looking for. If they're guarding, do you need to do deep palpation? No. Use your critical thinking skills. You don't. You shouldn't. The other thing that you will learn in your full initial assessment, you'll learn You'll learn percussion. You don't need to be percussing on your shift. What are you looking for? It's just for air. That's really what you're checking for. Air and fluid. So, you know, you don't have to do that either. But just to show you again, that is how it's done, okay? All right, and you need to know what you're listening for too. Don't just go tapping around on your patient. Timpani is what we're looking for. All right, so I have neuro, respiratory, cardiac, GI, knee, re, siggy. GI, is there anything else? I already checked the bottom because I pulled her over. Is there anything else? There is not. Now, what do I do with that GI assessment that was abnormal? I have a blockage perhaps inside of here. I need to tell somebody because they're going to need to get a KUV or something. They're going to need to get it, right? So I need to report that to the doctor. So GI, GU, this is your shortest assessment right here. Because if there is no variance here, they are voiding normally on their own. They don't have a Foley catheter. They're up ad lib. Perhaps they're checking eyes and nose. Maybe they are, maybe they're not. But if there's no deviation, you don't have to do anything. Why are you going digging for gold in your paint? Leave them with some sort of dignity. There's no reason to do it. What are you really looking for? But before I started that, I needed to ask a question. What question should I have asked? To assess.
Do you need to pee?
Any burning, irritation, itching, frequency. Very good, because I'm assessing for deviation, possible UTI, whatever the case may be. If my patient has a Foley, I have to look. Now I do have to look. Are you with me? If they have briefs, guys, you need to look and see, is there skin breakdown? You gotta look. But if it's normal, leave them be. Understood? All right. And when you're looking at the Foley, make sure you check for discharge. If you find it, get it cleaned and taken care of. And don't delegate that. You take care of that because that's your baby. All right, so knee, re, siggy, iggy, me, musculoskeletal. I've already done a huge part of musculoskeletal, but there's one more piece. I'm going to ask a question. What question can I ask? Are you able to move your arms around on your own? So ask them. Up in circles on your own? Ooh, sorry. Oh, she's videotaping. And she is. What if she wasn't? So that she was able to do it actively on her own. So that's active range of motion. And then we could do the same thing with the legs, up, out, all around. Good, she can. But what if she couldn't do that? I would have now, and you need to do it. Because if you don't, and your patient ends up getting contracted, bad mom, bad parent. Understood? Bad nurse.
What if it hurts them while you're doing it?
Then you go until they can't. You don't want to push beyond that. You go to whatever that limit is, and you need to notate the limit, how far that they can go, okay? Now, what if they can do one side, but they can't do the other? It's not symmetrical, but I have active range of motion on the right side, passive on the left. Are y'all with me? Knee, re, siggy, iggy, me. Baby eye, last eye. This is where I do my final sweep. I've already been checking eyes in every system, haven't I? So as a result, I usually use this for any of my lines. So I'm gonna check. I have my ACE, or you could do the lines within cardiac, whatever works best for you. But I use it as a full skin sweep. If I have any IVs, I'm going to look and see, do I have any swelling? Is it cool? Is it hot? Right? Is it painful? And I'm gonna look at the date. I'm gonna make sure that there's a date, because guys, if there's not a date on there, you don't know if it's been in there for 3 weeks and what are you gonna just leave it? You better work on getting your patient another IV, period. So you need to make sure that you date it, and then you have to make sure you're within the facility's time frame for how long it's supposed to be there. If it expires on your shift, change it. Don't pass it off, because that's your baby, as long as you can. All right, so I'm gonna do that. Maybe I have a central line. The other thing is, when you're changing, if you see your patient, sometimes this is just nursing. If you have a patient who has a dressing that's the change is due tomorrow, and you're not here, well, they can change it. It's not my shift, and it's bloody and it's soggy, and the bio patch it's got condensation on it, and it's change it. It's your baby. Knee, re, siggy,